All right. Hello, everyone. Thank you so much for joining our webinar tonight. Sorry for the technical difficulties, but I think we finally got it worked out. So again, thank you for joining our spring sports series brought to you by Rothman Orthopedics and NovaCare Rehabilitation. This edition in our series will focus on throwing injuries and how the sports medicine team works together to diagnose and treat throwing injuries and how we get our athletes back to the sport they love as quickly as possible. I'll turn it over to Natalie so she can introduce Dr. Brahmabhatt, and then we'll introduce our NovaCare team.
Yeah, absolutely. So thanks for having us. So my name's Natalie. I work in the marketing department here at Rothman, and Dr. Shyam Brahmabhatt, one of the speakers tonight, is one of our sports surgeons, and he is board certified in orthopedic surgery. Dr. B sees patients at our Willow Grove and Doylestown offices, and he specializes in arthroscopic surgery of the shoulder, knee, and hip, as well as knee and shoulder replacement surgery. And his clinical interests include complex injuries of the knee and shoulder, such as meniscus surgery, ACL and PCL reconstruction, patellar instability, articular cartilage restoration, rotator cuff repair, and shoulder labral repair.
All right. So Rob Caridi is a doctor of physical therapy. He works out of our Horsham location. Rob received his Doctor of Physical Therapy from New York Institute of Technology and has been on the NovaCare team for 3 years. He specializes in working with athletes with a special interest in overhead athletes. Katie Bartosik is an athletic trainer who works at Upper Dublin High School. She has been with us since 2005. She earned her bachelor's in sports science from Cabrini University College in 2002. And earned a master's in education from Temple in 2004. Katie is also a preceptor for Temple University's athletic training students and has experience as an adjunct professor with their Department of Kinesiology. Before we begin the webinar, I do want to let everybody know that we will be recording tonight's webinar for educational purposes, but only panelists are visible on the recording. So I will let Katie begin if you want to start to share your screen.
Great. Thanks very much.
Also, just to jump in, if anybody has any questions throughout, if they can type them in to the Q&A box or the chat box on the bottom of the screen, and then we'll get all the answers, all the questions answered at the end.
We can see this, right? Everyone's good? Okay. All right. So thanks again for having me, and thanks again for this awesome team presentation. I'm very fortunate here at Upper Dublin working with NovaCare. You know, we're doing this lecture series to talk about the sports medicine team, and I have a great sports medicine team with Dr. Brahmabhatt and Rob and his colleagues in our Horsham location. And if I can also shout out to my crew at our Fort Washington clinic too. They're really excellent people to work with. They know their stuff. And all of us have the athlete's best interests at heart, and that's what it's all about, you know, seeing these kids, evaluating their injuries, and then getting them back to the sport they love to play. So with overhead athletes and throwing injuries, I mean, everyone usually thinks of baseball, right? So you might get invited to throw out the first pitch. You want to have good mechanics. You want to have a good windup and a good delivery. What you don't want to do is that, all right? That's 50 Cent throwing out the first pitch at a Mets game. His mechanics are a little off, you know, obviously his accuracy is not there. So he's one of these non-overhead athletes that he should just stick to music and acting, I think. Like I said, with overhead athletes, everyone usually thinks of baseball, right? Especially pitchers, you know, they have that really high velocity motion. Their arm goes in all different directions with pitching. But with the spring lecture series, we're going to talk about spring sports. So we also at Upper Dublin, and if you're in the PIAA, boys tennis is going on right now. I need to shout out to my boys tennis team who made it to states. They're going to play next week. Boys volleyball is still going on. And again, another shout out to my boys volleyball team. They clinched their first ever conference championship on Tuesday. So they're having a great season. But also in the spring, we have lacrosse, boys lacrosse. Can't forget my softball athletes. Girls lacrosse is going on. And then track and field. So your field athletes, right? Your throwers, your javelin throwers, those who do shot put and discus, we can't forget about them, okay? That's all overhead motion that they do. And not to be left out, overhead motion and overhead athlete injuries occur in all sports, right? I see a lot of, we're going to focus on the shoulder a lot. So when, I see a lot of shoulder injuries in my swimmers, okay? Definitely a lot of overhead motion there. Soccer athletes throwing in the soccer ball from out of bounds. I mean, this guy looks like he's setting himself up for some low back pain as well, but definitely that overhead throwing motion with throwing the ball in. My water polo athletes, okay, just look at that. Look at that arm right there, right? Nice wind up trying to score that goal. Cheerleaders and gymnasts, we can't let, leave those athletes out as well. And I can't let this go. I am a Cowboys fan, so our quarterbacks, right? Our quarterbacks who throw the football, my boy Dak Prescott, he's going to be comeback player of the year, by the way, that's what I think. But all of these athletes do this repetitive overhead motion that can lead to a lot of injuries. So what do I see? I see injuries on the acute side, which means sudden onset, right? They happen at that moment right then and there. So I see a lot of sprains and strains. Now, not to be confused, you sprain a joint and you strain a muscle, okay? So that can happen acutely. A common injury, dislocation, whether it's a dislocation of the shoulder, a dislocation of the elbow, okay? A total dislocation of the joint happens acutely. Also, subluxations happen, and that's a partial dislocation. So especially in the shoulder, and there's going to be some anatomy slides coming up too, the ball in the socket of the shoulder, if someone gets contact and the shoulder shifts, that ball shifts within the socket, and that's a subluxation. Labral and rotator cuff tears are very, very common in our overhead athletes. You can see fractures, whether, that is, it can be in the upper arm, the elbow, and then your acute itis injuries. So for those of you athletes and parents on this talk, anything with the word itis means inflammation. So it's an inflammation injury. It's an overuse. The tendons and the muscles aren't used to the stress that you're putting on it, so they become inflamed. So you do see, and I do see, a lot of acute tendonitis and acute bursitis that might develop as well. And then there's this, and unfortunately in my setting, this happens all too often. An athlete will come into my athletic training room and say, Miss B, I've been having this shoulder pain for about 2 weeks. And this is exactly the face that I make, because I know that this is just going to take a long time to heal. The athlete will say, well, I felt it at first, but I didn't want to not play. I thought it would just go away. I kept going through it. I kept throwing. I kept doing the motion. And lo and behold, it didn't go away. And now it's worse. So on the outside, I'm doing this. On the inside, this really fires me up, because I've tried to get through my athletes that the longer you play with this pain, the more damage you're actually doing, and the longer it's going to take to recover. So I always tell my athletes to try and see me right away. As soon as you feel that pain, or as soon as you feel that something wrong is going on, come see me. Let me take a look, and we'll see what's going on. So this is oftentimes the chronic injuries that I see. Okay, now subacute, chronic is more like 3-6 months. That subacute phase is more like a couple of weeks into a month or two is when they have this issue. So that first one there is MDI. That's multidirectional instability, and that's really just a loose shoulder. The athlete, they can actually develop this. It can be a congenital thing, but it's really, really common in those athletes that do that repetitive overhead motion, and their shoulder becomes loose. So again, the ball in the socket, it's loosey-goosey to begin with. The more activity that you do, the more you're stretching that out, and it's more likely to sublux or more likely to dislocate. And that's usually because of weakness in the rotator cuff and the muscles that surround the scapula too. Going back to those itis injuries, okay, those are very, very common chronic subacute injuries, and examples are listed below. So tendonitis in your rotator cuff, impingement within the shoulder joint. I see a lot of biceps tendonitis, very, very common throwing injury. You can also develop that bursitis, again, inflammation of the bursa. And then some things that are not as common, or maybe not talked about a lot, epicondylitis that occurs in your elbow. So you have tennis elbow, everyone's heard of tennis elbow. That's pain on the outside or the lateral aspect of the elbow. And then your golfer's elbow, that is on the inside or the medial aspect of the elbow. And then there's little league elbow, and this is again common in baseball players. I don't see that as much. This is more of a youth sports injury because of the repetitive stress that is placed on the growth plates of the elbow. However, girls, their growth plates can fuse up until age 14 or 15, and boys 16 or 17. So I can see this at my level here at the high school. Why do I see these injuries? A couple different factors. The main one, considering the year that we've had with people learning at home, posture. Okay, we have to address posture when we talk about the overhead athlete, because there are so many muscles that affect the shoulder, you know, around the neck, and then that just leads to a domino effect of things. So bad posture everywhere. And this picture probably paints a good example of the past year, right? Everyone's learning from home. I'm guilty of sitting in one of these positions sometimes. I'm sure most of you are as well. So when you do this over a period of time, that takes, you know, an effect on the body. Again, another common position of students learning from home, I would assume. That just hurts me looking at it, that neck. This is also very common, especially in the high school population with teenagers, you know, and kids. They're in this position a lot, looking at their phone. So look at this. You have the forward head, you have the rounded shoulder. Everyone's looking down at their phone over a period of time. You keep doing that motion, that's going to have an effect. And this is actually something called tech neck, right? So the weight of the head when you're looking down at your cell phone, you're actually applying more stress to your cervical spine. And when that happens, think of all the muscles that are attached there. Okay, and that can cause more problems down the road. So if you just look at this picture from just a neutral neck, right, 12 pounds of stress. And the more angled you get, the more stress is involved on that cervical spine. So you get a lot of tightness, you get a lot of restriction there. That does add up. So how am I supposed to sit? Look at that top picture, right? Nice alignment. The low back is right in the chair. Good angles with the legs. Okay, good head angle looking at the screen versus how you actually sit. Okay, the picture of the cat there. All of this, like I said, if you keep doing that and sit like that and have that poor posture over a period of time, the body will adapt and you will have some dominoes falling, like I said. So a couple of those dominoes are muscle tightness, muscle imbalances, and then muscle weakness. Now, this all can play a role in those overhead injuries that I see a lot with all of my athletes. All right, otherwise, why do I see these injuries that I see? A couple other factors to consider. Poor preparation. Okay, so when your athlete is getting ready for their season, are they doing things in the off season to prepare? Okay, yes, are they getting their cardio? Are they getting their skills practiced with? But are they also doing proper strengthening? Okay, are they strengthening their arm? Are they strengthening their body, their core, their legs? What are they doing to prepare for their season or for their sport? Poor warm up. A lot of my throwers like to throw to warm up. You should really warm up first before you throw. Poor mechanics. Who's watching you throw? So this is just a picture of the mechanics of just pitching. Okay, but in those other sports we talked about, are your coaches watching your mechanics? Okay, swimming. Who's watching the mechanics of your stroke? Okay, that picture of the javelin thrower. Hopefully, you know, you have a coach that is watching your mechanics and making sure you're doing things properly with that throwing motion. And then poor recovery. I mean, here at the high school, everyone's so busy all the time, and I understand, and you want to go home and you want to eat dinner, or you have another practice to go to, or you have a club to go to, or you want to hang out with your friends. I try to tell my coaches, if you can set aside 10 minutes after practice, when you're giving your announcements at the end of the day, to let your team stretch. Okay, so stretch out after activity, get some of that soreness out, ice down when you're sore. Okay, all that over a period of time will help. Okay, so proper recovery, and obviously, you know, proper hydration, nutrition, and proper sleep also goes a long way in recovery and the prevention of injuries. Otherwise, all right, just poor overall muscle strength. The throwing is a full body motion, right? So it's not just about the arm, it's not just about the neck. Okay, you have to have a strong core. You have to have strong hip and glute muscles. You have to have strength in your legs to perform a good throwing motion. So whether it's your pitcher up in that right-hand corner there, your track and field athlete, or even if you're out on the golf course and you're not playing well and you want to just throw your club, you have to put your body into it, right? So again, throwing, it's a total body motion. Don't ever throw your club. That's not good, but just something funny to consider. Use your whole body when you throw. So what do I do when I see an athlete that comes into my room, whether I'm out at the fields, practice fields, or at games, or if I'm just in the athletic training room after school and my athlete comes into me, I'm going to go through my evaluation. Even if I see it, I always want to get the story from the athlete. So I'll ask them, tell me what happened. I want to get your point of view. Okay, so especially if it's not a contact injury, if they're coming in, again, in that situation where they've had the pain for about a week or 10 days, I want to get every single detail I can from the athlete, because then I can start to paint my picture as to what this injury might be. I'll ask them, where does it hurt? Usually an athlete with shoulder pain will do this, but I'll say, okay, if you can point to one spot where it hurts the most, let's try to narrow it down. And usually they'll say here in the front of the shoulder, or maybe in the back. And that can also help me narrow down what might be going on. When does it hurt? Does it hurt all the time? Does it only hurt with certain motions? Does it hurt if the athlete during the school day is reaching down to grab their book bag or sling it over their shoulder? Does it hurt at first in the morning, but then loosen up during the day? Okay, so all these history questions are very, very important to kind of lay the framework of this, of figuring out what this injury is. Any sounds going on? So again, someone with multi-directional instability, when they move their arm, might have crunching, or what I like to call Rice Krispies. Okay, there's some grinding going on in there. If there was a contact injury, was there a clunk or a pop? So I'll ask the athlete, did you hear anything, or even did you feel anything in the joint or on the area that hurts? I'll observe the athlete. I'll watch them walk into the room because I want to see what their posture is like. I want to see if they're favoring one side or holding one side. Usually, throwing athletes, their dominant arm sits lower than their non-dominant arm. So those of you at home, when the webinar is over, go ahead and look at someone in your house, dominant arm versus non-dominant, and you'll notice the difference. And then I'll go through my usual tests. So I'll do my range of motion tests. The shoulder itself, it's a very mobile joint, so it can move in all kinds of directions. But with that being said, with increased mobility, you sacrifice stability, okay? And that's why usually subluxations and dislocations are very common. So I'll take the athlete through all the ranges of motion that whatever joint is involved can do. I will then pair that with strength testing the joint. So I'll do muscle tests around the joint through those different ranges of motion. And everything's on a grading scale. And I will always compare the involved side versus the non-involved side, just so I can get a feel as to how bad the strength or the weakness is, or the range of motion is. And then I will do some stability tests to check the integrity of the joint. So let's start with the shoulder, right? It's a complex joint. There are a lot of ligaments there. There are certain special tests that I will do to, again, check the integrity of those ligaments. Is there any instability in there? Is there that clunking that I can feel, just general looseness? And then if I can, if the athlete is able to, I'll take the athlete through some functional tests. So I'll usually, the push-up is a great upper extremity functional test for strength and stability. You can kind of pair that all together. But if I don't think the athlete can do a regular push-up, I'll start basic and have them try and do a push-up on the wall. If they can do that, I'll have them use my treatment table and use that for balance and have them do a push-up against the table. And then if they can do that, we'll try a regular push-up. So everything kind of goes into progression throughout the course of these last components of my evaluation. And then after my evaluation, if I feel it's necessary, I'll hand off the baton to Dr. B. And what does that mean? So usually in those acute conditions, those acute injuries I talked about, if I suspect a fracture, if there's a, definitely a dislocation or a possible subluxation, they're going to need imaging right away. I'll send them to Dr. B right away. If during my testing of the athlete's ranges of motion or strength, again on that grading scale, if I don't think this is going to get better in a day or two, and I think some further diagnostic testing or further evaluation is warranted, go see Dr. Bay. We'll get a closer look and see what's going on. Any of those special tests that I do where I'm checking the ligamentous aspect of the joint, if there's any looseness in there, if there is a positive test with that joint integrity again, I suspect a tear, maybe a labral tear, maybe a tear in the rotator cuff. They're going to need an MRI anyway, off to Dr. Bay. And if I think any imaging needs to be done, you know, it's always good to get an x-ray, again, if I suspect a fracture or just to look at, let's say, the shoulder joint in general. I know Dr. B can write up a prescription and would want to see the athlete in office as well. So all of these things, I'll be passing off the baton to Dr. B, and then he'll see the athlete in his office, and then we'll go from there. So that's part one.
Katie, you'll have to sharing your screen. Perfect.
All right.
Can you guys see it?
No, not yet.
We can't see your screen. We could just see you. Do you see the little green?
Yeah, so it says share. Allow Zoom to share your screen.
Yes. Click yes.
Yeah.
And then either double click on the top left side where it says screen, either double click on that or then click the little blue share button at the bottom. Is it not allowing? Is it saying?
Yep.
There we go.
Got it?
There we go.
Sorry, guys. All right, so sorry about the delay. I want to thank everybody. I want to thank Kate from NovaCare, Natalie from Rothman, organizing this thing, and I want to thank my colleagues, Katie Bartosek. She is by far the best athletic trainer I've ever worked with. For the past 10 years, she has been a fantastic person that I take care of athletes with, and a good friend as well. And Rob, I want to thank you as well for joining today. And I want to thank people who are on this webinar, taking time from your family to learn a few things today. And if there's always any questions, feel free to ask us. So I'm going to mainly focus on the thrower shoulder today. Yes, there's a shoulder, there's a elbow component, there's a hip core component with throwing, but let's try and focus on shoulder today. We've seen this picture before, and probably you'll see it in the next talk as well, because these are the phases of pitching, the biomechanics. There's a wind-up phase, there's an early cocking phase, late cocking, acceleration, deceleration, and follow-through. Overhead athletes subject their shoulders to significant range of motions and torque, and thereby can have adaptive changes to their soft tissue and even their bony structures. And this especially happens when they're overhead athletes at a young age where their growth plates are open, so their bones can remodel in such a way. Large muscle groups of the legs, the trunk, the core, and the upper extremity help transmit force from the legs to the trunk to the upper body in order to release the ball. The transition between the late cocking phase and the acceleration phase is when most injuries happen. There is a violent acceleration that happens, and this is when injuries to the capsule, the joint lining, the labrum, or the rotator cuff or even the biceps tendon can happen at this stage. The peak velocity for while a pitcher throws, the angular velocity has been measured to at about 6,000 meters per second. So significant changes that can happen. And this is why you see people's arms go in positions that are not normal for us. But these guys have been pitching since they were children, and they have retroversion, meaning the bony component is remodeled much more different than their opposite side is. And this is where injuries can happen. But this remodeling is our adaptive way by our body to prevent injury to the shoulder. So the anatomy, so we have static stabilizers, and then we have dynamic stabilizers. The joint, the ball and the socket joint, as Katie alluded to, is by far the loosest shoulder, the loosest joint that we have, because we have such good range of motion. If you were to think about it, a ball, it's like a golf ball on a tee. And then there's the ligaments and the labrum that add to stability. The ligaments help position the ball in the socket better. The labrum and the capsule, the joint lining, give it a suction seal. So if you were to think of it, if somebody has a labral tear, when you hear an athlete has a labral tear, they lost their suction seal, and therefore the shoulder doesn't work so well. We were made in such a way that our center of the ball and the center of the socket should move only 3 millimeters. When you lose that suction seal, now it starts moving more, and that causes further damage to the shoulder. And usually the rotator cuff takes a beating, and I'll show you a picture of that later on. Dynamic stabilizers are rotator cuffs. So what Katie and Rob focus on in their training room or the physical therapy is that strengthen rotator cuff muscles. How does that help you? That helps you further keep the ball in the socket better, thereby having less issues. Pathoanatomy. So majority of patients that we see with overhead athletes is acute on chronic injury. They have been beating up the shoulder, as Katie mentioned. This has been going on for a while, and then there's a sentinel event, and they say all of a sudden things are in chaos. But this has been brewing for a while. So overuse and fatigue play a significant role in this. Gerd, this is one thing, if I can teach you one thing, especially for an overhead athlete, if there's a parent on the webinar or a athlete, GIRD. So that G stands for the glenohumeral joint, which is the shoulder joint. I stands for internal rotation, R stands for the rotation, and D stands for deficit. People who are overhead athletes will, by default, will have some deficit. But when the deficit gets to be more than 30 degrees, 40 degrees compared to the opposite side, the normal side, that's when pathology starts happening. So the job of the trainer, the physical therapist, and the surgeon is to teach the patient to make sure that they work on this range of motion to prevent damage to the shoulder. So the Phillies instituted a program for their pitchers to work on releasing the tightness in the posterior capsule. Posterior means back of the shoulder. That tightness in the back of the shoulder gives you Gerd. And if that is not done right, the ball starts going up a little bit and back, and now starts causing tears of the labrum, called a slap tear, and also causes damage to the rotator cuff over time. So in order to prevent injury, if you work on sleeper stretches, feel free to Google sleeper stretches, YouTube a video, see how it's done. I tell my patients how to do it. If you do this, this will help alleviate your Gerd, which is the rotation deficit that you have. Adaptive changes, if you look at an MRI of an athlete, an overhead athlete, and compare that to their normal shoulder, majority of patients in the major league will have rotator cuff tears and labral tears. Some will have full tears of their labrum and their rotator cuff, and they're pitching at a very high level. I had a picture of Roy Halladay before. He had rotator cuff repair surgery, and guess what? Things went downhill very quickly. Pedro Martinez, he used to pitch for the Boston Red Sox. He had rotator cuff surgery. Things went downhill very quickly. Rotator cuff surgery in a throwing athlete can end their career. So you have to be very careful as to what you're doing, because some of this is adaptive changes. You should not go and fix everything that you see. We talked about having increased retroversion. Their bones are positioned differently. This gives them alteration in motion and kinematics, but this is probably adaptive, may decrease injury rates. This is what Gerd is to the left, where the arrow is. This patient has been intubated. You can see he can only turn his arm so much, but look at his external rotation. Look at the difference that he has. You want to have some sort of symmetry, and there's obviously a difference here. So why do we care? Well, because this is what happens. So this, to put things in perspective, this is the ball of the humerus. Here's the socket. That's the biceps tendon. That is the front of the shoulder. Looking at it as front of the shoulder, we're looking from the back. This is the labrum tear right here. You can see tearing of the labrum. Labrum is a cartilage that surrounds the socket in a 360-degree fashion and causes, this instability causes tearing of the rotator cuff. This is another picture that shows that there's rotator cuff damage to the supraspinatus tendon. Here's the ball of the humerus. Here's your biceps tendon. And this is after cleanup. A cleanup for this patient will serve a lot better than trying to repair the rotator cuff that I would do for a 60-year-old patient. How do we figure these things out? Katie talked about an exam. You look at their strength, you look at their range of motion, ultimately get an MRI. But in the throwing athlete, a simple MRI does not work. So we have, for me and most surgeons, the gold standard is MRI with dye. It's called MR arthrogram. So a little dye is injected into the joint, and then the patient walks over and gets an MRI in a few minutes. If there's a tear, the dye sits in the crack and you can see the tear better. So that's a gold standard. This is what a labral tear looks like. So here is the front of the socket all the way out there. Biceps is at the 12 o'clock position. The patient is sleeping on their side. So the head is to the north and the legs are to the bottom right here. And this is the tear. This is the labrum. L should be attached to the glenoid, which is the socket, and a probe can really lift it off, okay? This is a good sized labral tear. You can see it sitting in the middle of the socket. Just imagine how painful that is. Not only is it painful and causing further damage, but because the patient has lost the suction seal that we talked about, that can lead to further damage to the rotator cuff. And once that damage happens, that damage is sort of irreversible. So to me, non-surgical management is key with these patients. You want to talk about activity modification, anti-inflammatory medications. As a surgeon, as a doctor, and as a parent, I think it's not right if you're having pain, you're taking NSAIDs and still pitching at a high level. If you're having pain, listen to your body and say, hey, I should work with my trainer or the physical therapist and say, I need to fix something. Because by continuing to play with pain, you're causing further damage. To me, pain is a good thing. If you have pain, you should stop. To us, in the sports medicine literature, no pain, no gain is BS. You have to say to yourself, stop. So what is Rob going to work with? He's going to work on the kinetic chain. I had one of my partner's friend come to my house and saying that he was having trouble throwing. And all I asked him to do was do a single leg squat. This kid's bigger and taller than me and cannot do a single leg squat. Why? Because your lower leg muscle mass matters. And if you have strength there, you can pass that energy from the legs to the trunk and trunk to the upper extremity. We already talked about Gerd. Gerd is something that Rob can work with, help release your tightness in the posterior capsule, which is the joint lining, and thereby reducing further damage to the shoulder. A lot of throwing athletes will have this syndrome called the SICK syndrome, S-I-C-K. S stands for the scapula, C stands for the coracoid, I stands for the bottom of the shoulder blade pointing at you, and K stands for kinematics. So these patients will have abnormal positioning of their shoulder blade, thereby causing significant damage. That can mimic that of a tear in the shoulder, and you might be fooled into doing surgery on these patients. These patients are better treated by Rob than me. Why does it matter? Why does physical therapy matter? Satisfaction rates are extremely high. If you look at slap tears, and in the major leagues, these are phenomenal athletes, right? These patients had very similar results with conservative treatment, similar to surgical treatment. But these are people functioning at a very high level. Now, if my 16-year-old child has a labral tear, probably needs to have somebody look at it. But if you look at it overall, just as Katie said, stop these injuries from happening and get help earlier on. at the end of the day, I want to show, we have Katie as our triage person and Rob taking care of patients before and after surgery with considered treatment. I just wanted to show a video in the end to show what a shoulder looks like. So this is what a shoulder looks like, the patient sleeping on their side. The ball is at the top, and you can see rotator cuff coming over here. That's a supraspinatus tendon. That's a biceps tendon. I'm looking for if there's any tears there. But you can see there's a tear right here in the back. And that's what causes damage. So that's a tear in the front. I've already put one anchor down below. I'm drilling, and then we're going to use a suture lasso to pass stitches through. And tie the labrum down to bone. And usually about four anchors in the front will suffice. And that's what it looks like in the end. But to me, I think this is sort of the easy part. You have to figure out, does the child need surgery? Does the child need conservative care first? Should they even have surgery? And these are the important decisions that get made by the trainer, by the physical therapist, by the surgeon. And then I coordinate care with the patient themselves, as well as the parents. And this helps us. And by the way, if there's any kids watching the webinar today, playing video games helps. If you want to be good at arthroscopic surgery, make sure you play a lot of video games. I played a lot as a child, so that will help you in future. If your parents give you trouble, call me. All right, that's it. I'm going to pass the baton on to Rob here. Okay. How do I quit? Stop. Got it.
Thank you, Dr. B. All right, I'm going to bring this up. All right, so my name is Robert Caridi. I'm a physical therapist at the Horsham NovaCare. And this talk obviously is about overhead throwing athletes. So you got injured, and now what do you do with the next step? So if you're injured at school, you're going to go see KDB. If she does her evaluation and determines that it's time to see Doc, Doc will do his evaluation, possibly imaging with the dye like he discussed. And then he'll refer you either for surgical treatment after surgery or non-surgical. So in the event that he does decide that it's to do a surgery in conjunction with us, you will be in a sling for a labral tear and a rotator cuff tear, depending on the time as per Dr. B. So when you come in post-surgical, you'll usually be in the sling. I'll ask you a history of the injury, what happened. I'll look at the incisions to make sure that the incisions are dry, clean, and intact. And I will do a range of motion assessment of your cervical spine, which is your neck. So I'll have you look down, up, side to side, and over to each side, just to make sure there's no issues there that will further contribute to your shoulder pain. I'll look at your elbow and wrist, active range of motion, and then I'll take some early passive range of motion measurements of your shoulder, which means I'll move your arm for you. And often Dr. B will set limits on how far you can move your arm at the beginning. And the most important thing is to follow his protocol. He was in there, he did the surgery. We have a protocol from him. We work together to make sure that we can get you back to fully where you were before surgery. In the event that it's non-surgical, we'll get the script from Dr. B, or I'll talk to Katie if it happens to be one of her students, and we're in communication constantly so that you can do what you're doing with me, also with her when you're at school. I like to get a history of injury kind of like Katie does. I want to know exactly what happened from you. And sometimes your parents are there and they come to the evaluation and they can tell me what they saw also. Then I'll do range of motion of your shoulder. And I like to look at this total shoulder motion, which is like Dr. B was talking about, the external rotation, which is all the way back versus that internal rotation. Throwers are going to have, because of those adaptations, a lot more external rotation, but we want to keep in mind where they are so that there's not so much of a difference from one side to the other, which leads to those issues in that Gerd that Dr. B was talking about. I'll look at also your thoracic mobility. A lot of the shoulders that influence, a lot of the muscles that influence the shoulder attach into your thoracic spine, which is the middle of your back. And so we want to make sure that we check that motion to see if there's any limitations there that are going to play into your shoulder motion. I'll check the joint integrity like Katie did for the shoulder. I'll use some special tests as well. And then I'll also check that scapular motion just to make sure it's moving how it should be. Like I said, I'll do a labral integrity test. Sometimes Dr. B has already done that too, or he's had imaging and he'll send that over to us as well so we can see what's going on. And I think the most important thing that I do is a strength assessment of not only your upper extremity and your shoulder, but also your lower extremities and a core assessment. I'll use the plank and side plank for these. The lower extremity assessment is used because when you're throwing, you're using both, not only your lead leg, but also your trail leg. So when your arm is over your shoulder and you're coming through, that lead leg is planted and holding a lot of force to prevent you from toppling over to one side or the other. You'll see some pitchers when they throw fall off to the base, one side or the other. And then I'll give you a home exercise program to start with at home. And then you can also do that with Katie following the initial evaluation. So the first thing that we want to do after surgery or non-surgical is restore that normal motion. Dr. B was talking about that sleeper stretch. You can see in the bottom left, she's doing the sleeper stretch. We want to stretch out the muscles of the neck. Also make sure you have as much internal rotation as you can compared to the other side. And then we'll start off strength. So these are just basic pictures, but isometrics is basically early strengthening. So after surgery, it's going to protect the joint. The arm is not going to move much while you're performing these strengthening exercises, and it's a good place to start. And then we'll progress to the more fun stuff, the Isotonix, which is basically movement through the whole range so that you can generate strength throughout that whole range. So this is a lot of the times when the athletes will have more fun and more enjoyable than doing the beginning stuff, but it's important to follow, again, the guidelines that the doctor has provided to prevent any further injury from occurring and any kind of setback, because that's what we don't want. We want to try to avoid any of that at all costs. So again, throwing is a full body motion. You can see, look how stiff that front right leg is, all that force going through there. And then when he gets to the next part, he's all that, the external rotation that's happening at the shoulder. So it really is a total body movement to be able to generate the force required to throw without being in pain. And like Dr. B was saying, a lot of the studies, you'll take these MRIs of these professional athletes and you'll see a lot going on in the shoulder, but that doesn't mean that you want to address those in a surgical manner, because you can, like you said, ruin their career. So then I like to have these goals to progress the patient to a plyometric program, which is basically more dynamic strengthening, that closed kinetic chain that Dr. B was talking about, getting you back to where you were prior to. So I like full range of motion of the shoulder, normal scapular mobility, and I compare this one side to the other, 0 out of 10 pain, and then 5 out of 5 strength, which means full strength as compared to one side or the other. And I'll check your legs as well to make sure that they're even. And then these are just some examples of some plyometric exercises. And these are the ones that I'll use in the clinic. And then they get obviously more enjoyable as you progress through the program. And then we get to throw together. So then when I feel like you've mastered that, I'll have you start an interval throwing program with a teammate, or something that KDB can monitor too when you're at the school. And I'll use a throwing program that has 5 phases. So it starts off with some warm-up throwing. Then you'll do 25 throws at 45 feet. You'll rest, because if you're pitching in a game, after you throw, you tend to rest. And then you have to go back out onto the mound after. So it's important that you don't skip that step. I have a lot of kids that will just say, I didn't really do the rest part. Well, that's important, because when you go back to playing full time, you're going to want to make sure that your body can cool down and start up without having any pain. And they're broken down from 45 feet to 60 feet to 90 feet to 120 feet, 150, 180. You go through that program every other day, and then you'll move to mound throwing. I like to start with fastballs, and then I'll progress to off-speed pitches. So this is my return to play criteria, and this is really where the full team comes in, because it's important that we're all on the same page when having the athlete go back to sport. Because me or Dr. B is not going to be able to see them play the sport. We're going to be in the clinic. he's going to be treating other patients at that time, but Katie can be on the field seeing how this is going. But this is the criteria that I'll use to discharge from PT and then return to play. No pain or swelling in the shoulder, full range of motion, full strength, normal scapular motion, pain-free progression through plyometric exercises. This is sometimes where we can, the patient's doing really well, the student's doing really well with some of those easier exercises. When we try to up the ante, that's when some of that pain can start, and we have to calm it back down. And then you complete the interval throwing program and then return to play. Those are my references, and thank you. So I'll send it back over to Katie.
Awesome. Thank you, Rob. Did you say back to Katie?
Nope.
Yes.
Yeah,
There you
sorry,
go.
I
There we go.
disappeared. I disappeared, but now I'm back. So let me pull up just a couple remaining slides here. All right. So you, the athlete, you've gone through each step of the sports medicine team. You've had your injury evaluated, treated. Rob and Dr. B have cleared you for return to play. You've worked through it, and now your season is over. What do? Well, prevent and maintain, because we don't want you to suffer the same injury or another injury, right? So what have you learned? Okay, first, practice good posture. Try your best. Okay, now hopefully I've put a little, something for you to remember as you go along. Warm up to throw. Don't throw to warm up. Okay, during your PT, you will be given exercises to do to warm up before you do the actual exercises. Okay, bring those back out. And with that being said, return to your rehab or your home exercise program. When you get that sheet of exercises from Rob or that packet, don't just crumple it up and stick it in a drawer somewhere. Those are yours to keep, and those will be beneficial for you for a long time to come, so much as long as you are doing that throwing motion. So don't throw those away. That's a good resource for you to continue to do as you prepare for your next season or game, if you're still in the middle of your season when you come back to play. So, it's not a one and done thing. Return to that rehab, return to those exercises. And then finally consult. I'm at the high school, Rob's at the clinic. Obviously Dr. B can see patients, but, Rob and I, we do complimentary consultations. I have set up screenings in the past here for my athletes at Upper Dublin. Unfortunately, COVID messed everything up the past year and a half, but I'm looking to get back to doing that next year. And then even if you want to call up the clinic and say, hey, I've been having this shoulder pain, can I come in for a complimentary consultation? And we'd be glad to do that for you as well. So with that being said, I thought I'd include a picture with me with my arms up, since this is an overhead injury. This is me in the Grand Canyon. Rob's information is listed below. My information is there, and then I'll turn it back over to Natalie. I think she has a slide with Rothman's information. And thank you so much for jumping on and joining our webinar. We hope you learned some good stuff. Thank you.
Thank you. We'll type in our information in the chat box so everyone can see it. And I think we do have a question. Kate, do you want to read up the questions? And
Yeah, absolutely. So this question is actually for Dr. B. What are your thoughts on biceps tendinosis in overhead athlete? Sorry.
So that's a very good question. And I think we have to quantify what level overhead athlete we're talking about. To me, if you talk about, say, Katie's patient population, which is a young athlete, you don't want to do a biceps tendinosis. That would be the wrong surgery for them. But anybody who's a fan of the Phillies, Curt Schilling, had both his biceps tendinosis done. Not while he was pitching, but in his later years. So I do biceps tendinosis for a 45-year-old guy, and they tend to do well, but he's not going to go pitch at the major league level. So trying to do a slap repair, like a labrum repair that I did on that patient that I showed a video on, If you do a slap repair on somebody over the age of 40, they typically don't do so well. So that's why biceps tendonitis is the answer. And for those of you who are listening, biceps tendonitis says biceps by definition, bi means two. So God, nature gave us a long head and a short head. So the long head is what attaches to the top of the socket, and you have a tear in its attachment site. So what do? Either you do a slap repair, which is called a slap tear, slap repair for a young athlete, or for a grown-up or an adult, I would do a biceps tendonitis where we take the long head biceps tendon down and reattach it at a different location. The short head still functions, and now the long head is anchored somewhere else, so you don't have the tugging pain anymore.
Awesome, thank you. Does anybody else have any questions they'd like to post in the chat box or the Q&A before we let everyone go? Okay, so Teresa asked, does icing help sore shoulders?
Katie, go for it.
Yeah. There's an argument that can be made. How much ice is too much ice? Does ice really help? Does ice really work? I say if the athlete is in pain, grab some ice for 10 minutes. It'll help with that. You want to be careful not to overdo it on the ice. Also, when you ice, you want to make sure that there is a layer between the bag of ice and your skin. I have had athletes fall asleep with ice bags or ice packs on, and they've woken up with frostbite the next day. So icing for 10 minutes, I think it helps. It definitely helps decrease the pain. So yeah, that's a yes for me.
What I'll add to this is you have to know when to ice and when to use heat. Ice for an acute injury, fantastic, right? But now you're in the post-operative phase. Say they're 6 weeks out from surgery. Sometimes heat actually works. I tell my patients, take a nice warm shower and then do your scapular stretching exercise, the sleeper stretches. And then when you're done with your exercises, ice the shoulder thereafter. So one has to know why we're icing, taking down inflammation. Icing works really, really well. But if you're trying to get a better stretch, then you're working on range of motion, then heat might work better for you.
Great, thank you. All right, well, if we don't have any more questions in the chat box, we'll give it another minute or so, and then we'll end about 4 minutes early, which would be great. Get a little bit more of our night back, right? Oh, here's one. Dr. B, what are your thoughts on PRP to attempt to avoid surgery?
Great. Another question. It's a difficult question to answer because we don't know what the injury we're talking about. I'll try to give you a couple of scenarios and let's see if we can help you. If you have Katie's Upper Dublin football player who has a quad contusion, muscle injury, and they're having a tough time with that injury and having a tough go at it in terms of coming back to sports, PRP is actually a good treatment for those patients where it's a muscle injury. And believe it or not, PRP got popularized by Heinz Ward of the Pittsburgh Steelers. They were going to the Super Bowl. He actually had a quad injury. They did PRP injections. Apparently he did well, won the Super Bowl, and now PRP is in the limelight. So PRP is plasma-rich protein. What we're trying to do is aspirate your blood, take some of your blood, spin it down, get the good stuff and inject it. There are two types, leukocyte poor, leukocyte rich. That means one has more white cells, the other one has less white cells. You're trying to use it for different reasons, inflammation or healing. So now that we say that if you have a muscle injury, PRP tends to work better. But if you have a rotator cuff tear where it's completely torn and you're a 55-year-old individual who fell yesterday, cannot pick up your arm, have a full thickness tear, PRP is not going to work, right? You can use it to augment, meaning you've done some surgery. If I do cartilage surgery, if I give a young patient somebody else's cartilage, I'll augment that with PRP to induce healing. But that alone itself is not going to fix the damage. Unless if there's a muscle injury, PRP tends to work well. Go ahead, Rob, what do you think?
So in the past, when I've seen PRP injections, I've had some good, some bad. I will say that in that scenario, I tend not to use ice at all. I'll only use heat in those scenarios, speaking about the ice or heat. And then often too, it's a graded return to their previous level as far as the strengthening goes and developing the range of motion. And you go from the same thing and you try not to hit any of those roadblocks that you hit prior that needed the PRP to be used.
Katie, do you have anything to add?
Unfortunately, I'm not well versed in the PRP stuff, but thank you for that insight. I do attend talks that talk about that topic because it is very intriguing what the results show. So.
Whoops, and looks like maybe one last question. We'll respect everybody's time, but Dr. B, what is your NSAID of choice?
For my back pain, it's always Advil, and I'm not making a single penny out of that. But I will tell you, for me, that works really well. I think you have to figure out what you're using things for. If my children have a little fever, Tylenol works really well. If they have inflammation, you need an NSAID. And what level of NSAID? To me, everything comes with a price. There's a risk-benefit ratio to everything we do in medicine. To me, Advil is fairly safe. Now then there's stronger ones like Aleve, that's only 2 tablets a day. Easier, but you're taking more of it. And then there's even more, Celebrex, Meloxicam. These medications have a side effect profile, and you have to figure out what do you want to do. To me, Advil works for me. It doesn't work that well for everybody, and you have to figure out what works for you, what doesn't. If you are a patient who has hypertension, things like that, be careful what you're taking, because these things can cause risk and increase hypertension, increase cardiovascular issues. And believe it or not, we never hear about this, but there are so many people who have GI bleeds because they take too many anti-inflammatory medications. And going back to our athletic population, I don't mind using NSAIDs. I tell parents when they come with the child, I told a couple today that I don't mind using it for 10 days, 2 weeks, and then we're going to say stop. Because if the inflammation is not going down in 2 weeks, something else is going on. We need to dive deeper.
Perfect. Thank you. And we just had just a comment. Excellent presentation, Dr. B, Rob, and Katie were awesome. Yes, I agree with that.
Thank you all.
Thank
Thank you,
you.
Dr. B. Thank you, Rob. Thank you, Katie. Wonderful presentation. I hope everybody gained a little bit of knowledge from that. And like Natalie put in the chat box, go to rothmanortho.com to schedule. The phone number is there, and reach out to any one of us for questions. Thank you so much, and have a wonderful night.
Thank you. Have a good night.
Good night.
Great. Thanks so much, everyone.
Bye-bye.
Bye.